Livia De Picker from Belgium, and some of our researcher colleagues might be able to talk to this about this. But you know, Belgium is a real heavy hitter for research in this area, and Livia De Picker, a bit like Joe, is a young researcher who's really on the cusp of the research and doing some really exciting stuff. And I'm hoping soon that we'll have her online. We're changing screens. Yes, we are online. So, Liv, I don't know if you can hear me, but we've given the introduction, and Lee might just text to say welcome, and it's over to you. Apologise for the delay. It's the end of the day for us. Whereabouts are you today? In what city?
Antwerp, in Belgium.
In Antwerp today. And the time there at the moment?
8:40.
Oh,
and I have to admit, I'm not a morning person at all, so it's good that it's afternoon where you are. That might help.
Well, welcome, and we really appreciate you coming in at this time of the morning. And so it's over to you. Thank you, Liv.
Thank you very much. It's a pleasure to be with you, and also many thanks to Equally Well for the invitation. So I'll be talking a little bit about the work that we did during the COVID-19 pandemic, and that is mostly colleagues here, healthcare workers, but also representatives of patients and families and carers in Europe, to protect patients with severe mental illness against the harmful effects of COVID-19. So here are my disclaimers. As you can see, I'm a member of some of the major European psychiatric associations like EPA and ECNP. I've also collaborated with some companies, but that is outside the scope of what I'm going to present today. So I'll be talking about 3 types of targeted actions that we've taken throughout the pandemic. So this was looking at vaccination strategies, the evidence on COVID-19 risks, and then also recommendations that we created. But obviously, I know we've all heard so much already about COVID-19, and you might be a little bit fed up with it, especially at the end of the day. So if you're wondering why we're still talking about COVID-19, it's because I truly believe that the work that we did, some of the findings that I will share, they are important and they will remain important for the mental health community also beyond COVID-19. And I hope by the end of this talk, you'll be convinced of that as well. But so first, going way back to the early stages of the pandemic. So in 2020, already just after the first wave of COVID-19 swept across the world, is when we saw the first reports of increased risks of adverse outcomes of COVID-19 in people with severe mental illness. And this is actually thanks in large part to the existence of national electronic health records that were available in certain countries that allowed us very early on to already have data on large groups of people to establish that there was indeed an increased risk. And this would definitely not have been possible about 10 years ago. So already very early we had the evidence, and it was both evidence of increased mortality rates and also increased rates of infection in people with different types of mental health diagnosis. So obviously, when you know that there is an increased risk, you would expect policymakers to take that into account when planning for vaccination rollout plans, right? Because you remember probably in the early stages of the vaccine rollout, there was limited supplies, and most countries therefore created some kind of national vaccination strategy where they defined certain groups in society that were going to get priority access to the vaccine. So usually that was the elderly above a certain age cutoff, healthcare workers, and then also people with certain types of medical comorbidities that had an increased risk. So wondering if people with mental health disorders were also going to be represented in those categories. And we were not the first, obviously, to point out that they should be included in these plans already, I think, here in December. So this was when the first vaccine was approved in the EU. Other authors had pointed towards ethical arguments for why people with mental health disorders needed to be in the priority plans. because they have already reduced life expectancy, because they were more vulnerable because of comorbid conditions and had an increased risk of COVID. And on top of that, our own group, I work in immunopsychiatry, by the way. So this is a field of research that believes that there is an immunological role to the development and illness progression of some of the major psychiatric disorders. So obviously, with that background, we also believe that there were just scientific immunological arguments for why these patients would be more vulnerable and should be prioritized. So we investigated if that was the case, and we reviewed the national vaccine plans that were publicly in the public domain in early 2021 of 20 different European countries, and basically just took over the list of the risk comorbidities, which you can see represented here on the horizontal plane. So there is different types of comorbidities that were typically identified as risk comorbidities for adverse COVID outcomes. And then for each of these countries, wherever you see tier 1 or tier 2, this is where that country would have given priority to that kind of disorder. But then on top here, you can also see the effect sizes. So these are the risk estimates of people dying from a COVID infection as compared to someone who would not have that disorder. So quite strikingly here, you would see, for instance, chronic pulmonary disease represented in almost every country national plan as a risk priority. But the actual effect size for the mortality is lower than that of severe mental illness, which was only represented in 4 country plans. So that was these 4, the UK, Netherlands, Germany, and Denmark. That were the only countries that had any kind of provision for people with severe mental illness. And then besides that, there were a number of countries, here the ones with the stripes, that did give priority to people in institutional settings, but that was just based on where they lived. So it was not depending on any kind of diagnosis. So we believe that this is something very different from giving explicit priority to people with a diagnosis of a severe mental health disorder, in particular, because these patients do not live institutionalized in the majority of the cases. And so they are at risk, even if they are just living in the community, as most of them are. So why was it? I think it was a really striking finding that out of 20 countries, just 4 had any kind of provision for people with severe mental illness. Obviously, we've spoken with a number of policymakers about this in different countries. And I think for the most part, they were just not aware. Policymakers were not aware of these increased risks in people with severe mental illness, and that is in a large part because the representatives of people with mental illness were not at the table where these decisions were being made. And in fact, I think the few countries that did do well on this, like UK and the Netherlands, they do have a tradition, a history of very vocal and strong patient organizations in the mental health community. And I think that made a big difference in those countries. On top of that, unfortunately, we did encounter also a number of very stigmatizing or just misinformed attitudes in policymakers. So we've heard policymakers say things like most patients are institutionalized anyway, which is obviously not true. Patients cannot adhere to the COVID-19 restrictions, and so they should be prioritized because they pose a risk to society. Well, so it's good that you give them priority, but it's not for the right reason. And then others just saying that the risks were not sufficiently proven, which was also not the case at the time. But so luckily, the work that we did with publishing, the information on these vaccination plans, and we did that together with 5 major European psychiatric associations, including also Gaming Europe, representing mental health patients, and UFAMI, representing families and carers. I think that had a definite effect. We also launched a major press campaign around that with global uptake. So we have seen in the days after our press campaign a change in several countries like France, Greece, Ireland, Latvia, Austria. One after the other, they started changing their plans and then including patients with mental illness, severe mental illness in the priority groups. And to further convince those countries that were still not convinced that the evidence was really there, we also took it one step further and we ran our own meta-analysis on the COVID-19 outcomes in people with mental illness. With the information that was available at that time, so this is May 21, we compiled 23 studies looking at mortality rates, hospital admission rates, and ICU admission rates in people with a pre-existing diagnosis of a mental health condition versus someone who would not have that condition. And so overall, in a sample size of just under 1.5 million patients, we found that the risk of dying from a COVID-19 infection, if you had any psychiatric disorder before the pandemic, was double the odds of someone who would not have such a diagnosis. And so on the graph here on the right side, so this is a forest plot, you can see all the different individual studies plotted. And the way to interpret this plot is the vertical bar here represents no increased risk. So this is just equal risk for both groups, with a disorder, not with a disorder. And every little dot that goes to the right of this graph indicates an increased risk. And to the left of this vertical bar is a decreased risk. So you can see that across the 23 studies, most studies have found an increased risk in patients with a mental health diagnosis. And taking everything together, this sums up to about twofold increased odds of mortality. Even we were the first ones to then differentiate between different types of diagnosis, because obviously there are differences in different patient groups, also just at the biological level. So we wanted to know which types of patients were at most increased risk. And this was also necessary because several policymakers refused to put mental health problems as a priority group because they wanted to know which diagnosis specifically should be included there. So we split the studies up or the findings up depending on different types of diagnosis. And so as you can see here, it is mostly the people with psychotic disorders or with severe mood disorders that were at the most increased risk of dying from a COVID-19 infection. Since then, this was 1 year later, we've confirmed that same finding in a meta-review where we again compiled all the available evidence available at that time, so in 2022, where we can conclude that there is evidence of an increased infection risks in people with mental disorders, especially in schizophrenia, anxiety, or alcohol-related disorders. There is some evidence of a higher risk of hospitalization, but not in people with psychotic disorders. And there is highly, highly robust evidence for increased mortality, so increased death rates in people with mental disorders, again, in particular, psychotic and mood disorders. So it's really beyond a shadow of a doubt, they were at increased risk. There were more deaths in people with those diagnostic groups. And I think we did not do enough to protect these patients, frankly. So what should we have done, or what can we still do with this information? How can we take targeted preventive actions? Well, obviously, everyone is looking at vaccines as the main way to protect anyone from adverse outcomes of COVID-19, and so did we. And then, of course, it was bad news when already in the summer of 21, there was the first evidence that there were actually vaccination lags in people with severe mental illness. So even if they were granted priority status, like in the UK, or if the vaccination supply was available for everybody, so there was no specific waiting times for anyone, still there were lower vaccination rates in people with either severe mental illness or in particular schizophrenia, despite them having more comorbidities and being more at risk. So they should have had a higher vaccination rates, but the actual observed rates were lower. And so this caused the whole debate about why this was happening and if these patients were maybe unwilling to be vaccinated. We've proven here in Belgium that that is not necessarily the case. So in our own study here in Belgium, we've seen that if you target patients where they are, if you meet them where they are and you create a vaccine program that is different from the rest of the population. So here in Belgium, in order to get vaccinated, you would get either a paper letter or a digital letter, and then you would need to click on a link and make a booking at the vaccination site, and then go to that site, which was a big space usually with lots of people running around, and you would not know anyone there. You would need to take public transport to get there. So that's quite challenging, I think, for people with severe mental disorders who may be anxious to be in big open spaces with people that they don't know, or who might not be able to take public transport or to book the vaccination slot. So what we did is that we were able to get a batch of vaccines, COVID vaccines, at the psychiatric hospital site. And then we distributed those vaccines to the patients residing in that hospital, but also all of the patients that were in the community around the hospital, being served in our catchment area, being seen by healthcare workers in our area. And they would be given that vaccine by the healthcare worker that they were familiar with, so the nurse or the psychiatrist that they were already working with for their mental health care. And doing that, we saw actually a comparable or even higher vaccination uptake compared to the general population. So it might not be so much a case of vaccine hesitancy, but rather barriers that were limiting access to vaccination in certain patient groups. And I think this really calls for a proactive approach to ensure vaccine equity. So we need to do everything that we can to remove all of these barriers. And I think we really need to involve also the existing care network of patients, not just professionals, but also families and carers and anyone that can help us to raise the vaccination rates in these patients. So we created some European recommendations, again, with different collaborating organizations. We were also part of the Equally Well global call to action, calling for actually the same types of proactive approaches. So is that the end of the road? COVID is gone, and well, it's nice that we did all this and let's get back to business. Well, I don't think so. I think it's definitely not the end, and a few things that we've learned throughout these past years we should really take with us for our future actions, because there are still a lot of questions remaining unanswered. Well, firstly, COVID-19 is actually not gone, and there are still preventable deaths happening. And still, we are going to see COVID-19 boosters being rolled out to vulnerable populations. So we need to make sure that patients with mental health disorders are on the list of the vulnerable populations that are given priority or access for free to these vaccines. And also, very importantly, we need to know why. Why are these patients more at risk? And how do we protect them from vaccine preventable disorders? Because there is some evidence, and this is unpublished data, we've just submitted this, that even if you manage to get good vaccination uptake rates in people with schizophrenia, for instance, the vaccines, so the normal vaccination plans might not be so effective in these patients. And we've done this study together with colleagues in France and also in the United States. So we've collected a patient sample of patients with schizophrenia, schizoaffective, both inpatient and outpatients, and then compared them to healthy controls, looking at the COVID spike antibody after vaccination. So this is a way to measure how much antibodies someone has produced in response to the vaccine, which has some indication to the level of protection. We don't know exactly what is the cutoff for how much antibody you need to have to be protected, but we know in general there is a correlation between the level of antibodies and the actual protection against COVID-19 and adverse outcomes of COVID-19. So in this graph, you see in the blue the patients with schizophrenia, in the red the healthy controls, where at first, so this is the number of days after the first dose. So in the beginning, the first 20 to 40 days, it seems like both lines are mostly comparable to one another, but the further you move out, so the further time advances, the further the two lines are from one another. So this is an indication that the long-term protection is not so good in patients with schizophrenia. And if we just look at the samples that we had of patients after the second dose of vaccination, so this is in between 14 to 28 days after second vaccination. So usually it's said after the 2 doses, 3 weeks later, you're protected. Well, that is only the case if you produce an adequate level of antibodies. And the patients with schizophrenia did not have the adequate level of antibodies in our study. Obviously, this needs to be replicated in further larger studies, but I think it's hugely important because it's the first direct evidence of a possible lower vaccine efficacy in people with schizophrenia. And if we go and look at the literature of what is known about vaccine response in people with schizophrenia, that it's appallingly scarce. So there are a few studies from the 50s and 60s and 70s looking at this in different types of with different types of vaccines, but this is before DSM-3 even, and before novel biological assays that are able to accurately measure antibodies. So we really can't rely on those findings that much. And then more recently, there are some indirect studies, so for instance, showing a higher grade of breakthrough infections in people with schizophrenia that are vaccinated, which is confirming actually our finding, but it's indirect, whereas we're the only ones who've now shown that it's a biological thing. They're not producing the right amount of antibodies. So take-home messages, I think, well, people with pre-existing mental illness are at increased risk, double the odds for hospitalization and mortality. So really a proactive approach for vaccine equity is very, very necessary. And we need to really prioritize research on these infection risks and the vaccination of patients with severe mental illness, not just for COVID-19, but for any vaccine preventable illness, because it's very likely that it's not just limited to COVID-19. And in fact, there is evidence that it's a general effect where they're more at risk of any kind of infection and not producing a proper immunological response to any kind of vaccine. So maybe they need other doses of vaccinations or a different vaccination strategy. So that is still totally unanswered, but I think it's really necessary to study this. And so for psychiatrists and healthcare workers in general, I think we really need to step up and step into our CanMed's health advocate role and collaborate with other stakeholders to bring change, because we've proven that it's possible. So yeah, I think this is my main message. And if you enjoyed this presentation, I'm happy to take any questions if they're there.
Thanks, Liv. We've actually, I know you've got some commitments and we're running a little bit behind time. So I think if there's any questions, we'll do them online. But I think this is a great example. Earlier today, we had some research that's done people's recovery experiences. And now we're looking at your research, which is looking at antibody levels, etc., and also your advocacy at national and international levels. And part of Equally Well is a collective impact approach. And each part of this collectively, through to advocating nationally, through to describing people's recovery journeys, through to the fantastic world-leading research that you're doing, all of this is part of advocating and moving towards better, improved health for people living with mental illness. So on behalf of us all at the Australian Equally Well Symposium, can we please thank Dr. Livia De Picker.
Very much.
Thanks.
And also thank you for the excellent work that you're doing.
Thanks, Liv.
Looking forward to collaborating in the future.
Yes, that would be great. Thanks, Liv. Bye.
Thank
Bye.
you. Thanks, Russell. That was a fantastic presentation. Thank you very much.